time to acknowledge the other colleagues who are just joining us. Please keep putting your name, your organization, and the country you're joining us from in the chat while we comment. So, colleagues, today we're having a very important conversation on building resilient communities. And this is a necessary shift in how we prepare to or prepare for and respond to public health emergencies. Over the last few years, if you'd recall, one thing has become clear, especially from the COVID-19 pandemic that we had, that outbreaks or public health emergencies start in the communities and it actually ends in the communities. In public health, we do a lot of infection prevention control, case management, operation support, and logistics. While all of that is critical, you know, it is actually what happens outside of those walls in the homes, in the markets, in the places of worships, in the border crossings that actually determines how fast we detect, how fast we contain, and how fast we respond to a public health emergency. So, to this end, WHO and the other partners, by the other partners, we mean IFRC, we're talking about UNICEF, the other agencies. We're now placing a greater emphasis on community engagement, and you will hear things like community-based surveillance, collaborative surveillance, cross-border efforts. All of that is at the heart of community health, the community health workforce, which is also a trusted link between the formal health system and the community. So today, the panel that we've put together will be discussing and telling us powerful lessons and stories across the continent on how each of these member states have integrated the community health workforce into their emergency preparedness and response system. Today, I will be your moderator. My name is Amarachi. I'm a training officer with the WHO African region. May we have the housekeeping up, please? Correct. As usual, WHO events are guided by the highest ethical and professional standards, and all of us in the room, participants and panelists, are expected to behave with integrity and respect towards everybody who is in the room. To the next slide. Now, we have interpretation available in English, in French, and in Portuguese. If you look at the bottom of your screen, you're going to see a globe icon that has interpretation below it. If you click on it, you can then access the different languages that you want to listen to this session in. Please use the Q&A also at the bottom of your screen for questions regarding the topic or the conversation that we're having today. You can use the chat to introduce yourself or for IT issues, as we're already doing. Tell us your name, tell us your organization and the country that you're joining us from. After the after the panel discussion, we will be having a live Q&A session. I want to encourage that all participants that have questions should raise their hands, and they will be given access to speak, and they can interact with the panels and the panel moderators live. Next slide. Kindly note that by participating in this meeting, whether as a participant or as a panelist, we take your attendance as permission to record your contributions. So all of your questions and all of your contributions. And we will be sharing these contributions on our various learning channels for continuous learning purposes only. Now, the materials, we have some resources for you. Each of the countries on the panel have prepared some learning resources that you can take home with, including the session recordings will be shared with you in the days following the webinar. Next slide. For all of the data that we collected from you during registration, all of these data is kept very confidential with WHO. We may use some of this data for reports, for maps, for communication, for surveys, but I assure you that all of it will be de-identified before use. Next slide. So today, I have just done the setting the scene, objectives, and the housekeeping. We will have opening remark by our uh, uh, program area manager for the Health Emergencies and Pandemic Preparedness Unit at the WHO African region, and he will be joining us in a minute. Shortly after that, we're going to have some interactions on a virtual tool, and then we're going to move on to the panels. While we're waiting for uh, Dr. Dick to join us, may we move on to the sliders? So if Sangamitra will stop sharing her screen, we can move forward with the Slido interaction while we're waiting for Dr. Dick. Colleagues, may you confirm if you can see my screen? Participants, you can use the react button to give a thumbs up if you can see my screen clearly. Can everybody see my screen? Panelists, can you help me? Can you see my screen? Okay.
Yes.
Okay, colleagues, take out your phones. You can scan the QR code that is just on your far left, and you can join the call. You can join the poll and give us your opinion while we wait for Dr. Dick to join us. Aditi is also going to be putting the link to this in the chat, colleagues. Tell us your opinion um, on what are community health workers called in your country. It can be in your local language, it can be an official term, it can also be in English. Yes, colleagues. Great. Community health promoters. I'm going to leave the French words to Julian to manage. Community health workers. Okay, we have a lot of community health workers. Colleagues, you can also scan the QR code on the far left of your screen, or you can join with the link that Aditi has just put in the chat and tell us your opinion. What are community health workers called in your country? Can be in the local dialect too. Thank you so much. Right, we have a lot of community health promoters and community health workers. Great. We'll give another 1 minute for this, and then we move on to the next question. We have our program area manager on the call, and he will take up from there. All right. I see village health teams, very interesting. Great. So next question. What is one word that comes to mind when you think of community health workers? Colleagues, if you look at your screen, a new question has just popped up. What is one word that comes to your mind when you think of community health workers or the community health workforce? We have outreach, we have community health promoter, we have mobilizers, indispensables. Okay, great. Health promotion, great. Community health promotion, very interesting. Health close to the community, very interesting. Empowerment, interesting. Influencers, disease surveillance, thank you. All right. Okay, colleagues, we're going to end this session very quickly in about a minute. All right. We have access, great. We have bridges, very good words. Thank you. Community volunteers, very good. Okay, colleagues, thank you for participating in the sliders. We still have it open, by the way, so you can keep sending in your responses. But right now, I'd like to hand over to Dr. Dick Chamla, who is the Program Area Manager for the Health Emergencies and Pandemic Preparedness Unit here at the WHO African region. Over to you, Dr. Dick.
Yes, actually, good afternoon, everybody, and others in other time zone to be, I think, good morning. I'm Dr. Dick Chamla, as introduced, and I'm the Program Area Manager of Emergency Preparedness and Threat Management here, the WHO Afro. And in Afro, in the preparedness team, it is where a community health program actually lies and included. So I'm extremely glad for our team to organize this critical meeting on community health workers. In the WHO, we have a phrase in which we recognize by saying emergencies are commencing and ends in community. So it is absolutely critical to involve full community in ASA planning, in detection, in preparedness, and response in the emergencies. As I'm talking now in Africa, we have around 88 emergencies in which we are tracking, and we're only halfway. The last year, we had over 154 public health emergencies. And the emergencies I'm talking here, it includes outbreaks and also it includes humanitarian crises in which are all over Africa, and I'm sure, as you know. And our problems, in many years, we have been prescriptive in our approach in emergency preparedness and response. Prescriptive in the sense we have the guidelines, we have the money, we have everything, and we tell our member states here are the best practices you should do. And now we recognize we have the local best practices in which we don't know ourselves. And I think it is the dialogue, it's a global discourse now on how are we able to optimize capacities and the knowledge of community health workers in order to help us in preparedness and response. Our problem, however, has been on the literature and understanding of community health worker profiling and the numbers and their structures. For us, we had time in Asia, we've seen actually Indian ushers. They are actually highly skilled, they have reporting forms, they can even deliver babies. In Pakistan, we see the lady health workers, LHW, in which are doing a number of issues, also including the detection of polio, acute flaccid paralysis, and others. In Yemen, we have health shuras, actually, in which also have skills and the knowledge in which has been applicable. And in Africa, if we return health extension workers in Ethiopia, we have enough literature on how we have improved health outcomes. Also, a lot of other people don't probably aware that in Ethiopia also have the Health Development Army, in which it is actually another layer of community health workers, in which also supported. Rwanda literature is also still the same. We're seeing the successes in community health workers. However, in other countries, the level of community health worker is still under development, and others is still advanced. And in the past, we didn't have a platform in which we were able to bring everybody into place and see actually what is happening in their countries. And now I think it is a beginning of our dialogue and see actually from which country are the best practices lie in which it will be enabling us. We have seen issues of the payments of community health workers in which is coming. We have realized also with other partners are creating their own cadres of community health workers. The WHO, UNICEF in the past, we had IMCI, a community MCI, and we had ICCM at one time. And we don't know actually what is in actual what is happening in either ICCM or community IMCI, and we'll be actually happy to hear it here. Therefore, I'm really happy we're here. And as in emergencies, we are really, really interested to understand how community health workers are playing a greater role in emergency preparedness and response in Africa. And I will end up here to congratulate all of you. I see we have over 100 people in actually in the call, but I'll be here in the call and see. I'll be interested to hear actually what is happening in Africa as far as the communities are concerned. Preparedness team in Afro also is a place in which we actually coordinate pandemic fund application process. And from the guideline of the round 3 of pandemic fund, a community program is also prioritized. As a result, it shows clearly globally community health work is actually higher in the political agenda. Therefore, we'll end up here and return to Anokwa, I think, he to conclude with the deliberation and Mercia to serve.
Thank you so much, Dr. D. Colleagues, we will now move on to the panel discussion. We will be talking about building resilient communities and community health workforce engagement in health emergency preparedness and response in the across Africa. My bad. The session for this session, we'll be looking at how community health workers are being trained and equipped in the different countries that are on the panel to address the different type of emergency. We'll also be talking about the countries will also be talking about their critical roles in risk communication, detection, and preparedness as a whole and response. The countries will also tell us how their individual member states are fostering coordination and leadership among the community health workforce and their strategies to strengthen community level resilience through the engagement of this workforce. So for today, I'm going to be introducing our first moderator, Elodie Ho, who will be moderating the panel on From Detection to Action, Strengthening Community Health Workforce Capacities in Emergency Preparedness and Response. Elodie is a social behavior change specialist with over 15 years of experience in leading emergency projects in Asia, in Africa, and in the Middle East. She is the Africa Infodemic Response Alliance Coordinator. We call it IRA over here for the WHO African region. And in this role, she also piloted the infodemic management approaches to combat misinformation, disinformation, and to improve information ecosystems across the region. Over to you, Elodie.
Thank you very much, Amarachi, and thank you to all of you who are on the call today for this very interesting webinar. I would like to first start with experience from Kenya. And for this experience sharing, we have Dr. Richard on the call. So Dr. Richard Kabanda is the Commissioner of Health Services in charge of health promotion. He's charged with leading the public health agenda. I'm sorry. So for Kenya, we have Philip Ngere. Philippe Ngere is a medical epidemiologist who supports public health intelligence and population health activities at the Kenya National Public Health Institute. So, Philippe Ngere, if you can answer these questions. So, in Kenya, can you tell us a little bit more about the progress that Kenya has made in the last 2 years to strengthen the integration of community health workers into the county level emergency preparedness plans? So over to you.
Thank you so much, Elodie. Good morning, good afternoon, fellow panelists, colleagues, and organizers of this wonderful webinar. Allow me to start by first of all giving a small background on the Kenyan setting. Kenya, in terms of governance, has two levels of governance. We have the national level and also we have the counties. These two levels are distinct but interrelated. The design of the healthcare service system in Kenya is based on these levels of governance. We have the national level facilities that provide highly specialized teaching and research activities. Then below the national level, within the counties, we have the county referral facilities that also provide comprehensive specialized services. And below that, we have primary care facilities because that provide, again, primary care services. And most importantly, related to the discussion we're having now, we have the community health services. This is domiciled within the facility, within the communities. We don't have any physical facilities. And primarily they do health promotion work. They also do, community-based care generally. We'll get to appreciate the details later. So this community level services is organized into what we are calling community health units. And maybe before I get into that, it's important to appreciate that community health services are part and parcel of the national healthcare service delivery system. They're not separate. So this level is organized into community health units. These units comprises of approximately 5,000 people per unit. They are headed by, these units are comprising of around 500 people. That's approximately 100 households. And each community health promoter, as we call them in Kenya, will be in charge of these households. And when you put together around 10 community health promoters in charge of 100 households each, you get a unit headed by a community health assistant or a community health officer. So this is the structure of the community health services in Kenya as of that. These community health services, health units carry on a lot of activities, and in the recent past, we've been able to have them support, emergency preparedness and response activities, including issues to do with prevention of, these public health threats. And a number of tools have been deployed to support this. One particular example is the use of the early warning systems, which is a component of a surveillance system. And classically, we've seen where this system is able to detect, outbreaks or indicators of outbreaks way before they become overwhelming. They participate in surveillance activities. A lot of community-based surveillance activities happen in Kenya. I think it's the most robust of our surveillance activity system. We have community disease surveillance system where they track priority diseases using latest definitions by visiting households in their jurisdictions. We also have community event-based surveillance where they report on occurrences that may present acute threats to public health. They participate in mortality surveillance. A lot of rapid mortality surveillance currently being done in regions where community event-based surveillance has been deployed, as they also take note of community deaths and report. They're involved in screening, a lot of screening activities. Whenever they visit households, they conduct screening activities. Whenever there is need to conduct community specific community screening related to specific threats, they're also engaged and they're able to do that. They're also involved in response activities to these emergencies and other public health, events. They conduct management, they conduct home-based care, they conduct risk communication, IPC wash during response activities. And they're also involved in, contact tracing and follow-up during, public health events. They're also involved in continuity of services, essential services during emergencies. Like I said before, they provide some community level care. This include, of course, health education, health promotion, some immunization activities, linkages to facilities, nutritional activities. They also conduct referrals. And of course, during public health emergencies, when sometimes systems break down, they become very valuable in the sense that they also stay within the communities and they're able to provide this valuable linkage for services to continue. A lot of things have happened in Kenya that we consider enablers for this kind of service, these services to continue. And I just want to speak to a few. One of them is that community health services is anchored at the presidency. This gives it, a very high level kind of buy-in. We've seen, the president involved in issues of launching community health services activity, supporting the activities. And the country really looks at community health services as a means of achieving our objectives in the universal health coverage. And because of that, then, it gets a lot of support. We also have, the service in itself being part and parcel of the healthcare service, so that it's not treated separately. It is not put on the sides, but it is part and parcel of the, a holistic healthcare system within the country. A lot of financing is now also being done to this end. We have what we are calling the public healthcare fund, and this public healthcare fund provides an opportunity for community health services to tap in, and this is the component of one of the components of a social health authority, fund. The country has passed laws that provides frameworks within this community health services, engagement of community health workforce occur. We have the Primary Health Act, which stipulates who gets to be a community health promoter, what they need to have, what they need to do, what are the ethical expectations of them when they conduct this. After the Public Health Act, we've gone ahead to, develop the policies, we've gone ahead to develop the strategic plans and even the curriculum for onboarding, appropriate eligible people into this healthcare system. We have a toolkit, a community health toolkit that they use to provide the services. These were unveiled by none other than His Excellency the President, which fits into that buy-in that I talked about. And this is a kit that they use to provide services. It contains some equipment for taking vital measurements, some screening equipment. It contains even some consumables and some basic, therapeutic commodities. The healthcare service system is completely digitized. And this, for us, in emergencies and public, emergency preparedness and response is key because it facilitates accuracy in data, timely reporting, and also even feedback. So the system is paperless through and through. We have two platforms that we're using. We have what we are calling the Electronic Community Health Information System that is largely the mother platform. It does all the modules, including the training modules, the data tools for collection and submission of the various data that is being done. We also have what we call M-Dharura, M for medical, Dharura in our local Kiswahili word means emergencies. This is used for community event-based surveillance. Through this M-Dharura, then be able to detect the signals of interest and report them rapidly to trigger subsequent public health response activities. Again, in Kenya, we have a robust network of civil society organizations and stakeholders that really is working hand in hand with the government, collaborating with government in partnership with government activities to support the rollout of the community health services. Recently, the country rolled out or launched the National Public Health Institute that now takes over the responsibility of coordination and integration of some of these services, especially related to public health and emergencies. And through this, again, we are seeing their services being concretized and being solidified so that it's more focused and more effective when it comes to emergencies and other public health events. That notwithstanding, of course, a few barriers come to fore. Top of this are sociocultural, beliefs and practices. Kenya is diverse. We have a number of ethnic communities with diverse beliefs and practices regarding, behavior and practices that are related to, health outcomes. And to that end, sometimes it becomes challenging to have them address all this if they also subscribe to some of those beliefs. I know we address this through during capacity building and trainings and sensitizations, but sometimes that becomes a bit of a challenge. Issues of safety and security cannot go unmentioned. As much as we engage the community health workforce in our emergency and public health, response activities, it is important that we appreciate that they also need to be protected. They also need to be secure. And sometimes in the face of limitations, this exposes them and maybe due to emerging conditions before they actually get to be noticed, sometimes they end up being exposed before proper measures can be put in place. Our community health system is very robust. Currently, we boast of over 100,000 community health promoters covering the entire country. And because of that, it translates into it has very huge economic implications. This then calls upon us to think about sustainability and how we can have this run effectively and efficiently. This is still a small challenge, but work in progress, and over time, I know we shall overcome. I want to stop there and give it back to you, Elodie.
Thank you very much. This was a very comprehensive presentation of the community health services in Kenya. Thank you so much for sharing your experience and also how the community health workers are part of the whole system, the health system, to achieve universal health coverage in Kenya. That was really interesting. And I saw in the chat that your experience has already triggered some questions, and we'll keep them. We have a dedicated Q&A session a little bit later. So thank you for that. Now, I would like to I would like to introduce our colleague from Uganda. And apologies for the confusion earlier. So now we are going to introduce Dr. Richard Kabanda. So Dr. Richard, I hope you are with us. So you are the Commissioner of Health Services in charge of health promotion in Uganda. And you are in charge of leading the public health agenda in your country through health promotion and disease prevention strategies. You are the current chair of the Africa CDC Community Health Working Group, as well as an expert advisor to World Health Organization globally on the strategic group of experts on health promotion and well-being. So, Dr. Kabanda, I have a question for you. In Uganda, what lessons did you learn from engaging community health workers during the 2023 and 2024 Ebola response? And how did those lessons are now being applied to other emergencies? So over to you, Dr. Kabanda.
Yeah, thank you so much for the introduction and for the opportunity for us to be able to share. Of course, my colleague from Kenya has hinted on quite a number of things. There's quite a lot of similarities on what community health workers do. Of course, to take you back, Uganda has so far had 8 Ebola outbreaks. And I suppose there are many of our colleagues from other countries have not had an opportunity, let me call it an opportunity, to experience such a bad opportunity to experience Ebola outbreak. It's really life-threatening, both for the professionals, the healthcare professionals, the communities, and many more other key stakeholders. And of course, community health workers are part of our health system in the country. We do have 2 layers of community health workers. We still have a layer of volunteers at village level. Currently, up to end of this year, we talk of on average of 3 to 4 volunteers at village level. Starting from next year, we are mainstreaming. Also ensure that the volunteers at that level are mainstreamed, and we shall only be having two per village. But these are part of our system, and they form part of our health, our level 1 healthcare delivery. We have almost 7 layers in the country, and beyond the other layer of volunteers at parish level, parish or ward level. Parish level comprises of an average 4 to 5 villages, and we have 2 of them. They undergo 6-month training, and these are provided with incentives, and they are also equipped to undertake both communicable and non-communicable health promotion disease prevention initiatives. So, but these are also supervised by public health practitioners who have undergone a lot of intensive training in health promotion and prevention. They are basically professionals who are based in health facilities, but undertake health promotion activities within facilities and also communities. To get specific, we know that there are quite a number of roles our community health workers do during outbreaks, and specifically for the Ebola one. The most common one, which is known, is community-based disease surveillance, one on contact tracing, but of course also on reporting. And we are happy to let you know that we adopted a digital reporting for them at that level. But they are also involved heavily in public health risk communication and community engagement. They have been doing a lot of public health awareness at community level, at village level. But to be very specific, also, our community health workers support us in social listening and evidence generation. Most of our community feedback mechanisms are routed through the community health workers. So we are proud to say that, of course, some of you have been a part of Ebola responses. You must heavily listen to the communities. And of course, effective contact tracing happens if the communities are more responsive. And the communities cannot be more responsive if the community health workers are not very, very active. So they have been supporting us in social listening and evidence generation. And specifically for evidence generation, we are much more concerned about some of the anthropological data that comes from communities, more so the high-risk communities. And of course, you know that medical anthropology is very, very critical when it comes to EVD response. Community health workers have also been instrumental during these outbreaks in mapping critical stakeholders, especially in the high-risk geographical areas. Stakeholder mapping, engagements, and of course also supporting us in the response in social mobilization. There has also been, they have also supported us much in risk assessments, because sometimes at national level, you may not have a grip of what happens at that level and which communities are at high risk. So risk assessment has been much more done by the community health workers, of course, guided by our epidemiologists and also the public health actors. The other critical area where we have had community health workers supporting us is in the conducting of unified barriers. But of course, you know, in countries that have been responding to Ebola issues, especially here in Africa, what is very common are the cultural beliefs when it comes to conducting barriers. And of course, the very first outbreaks, dignified barriers were heavily conducted by the IPC teams professionals. And of course, the experience was that in many communities, even despite having conducted a lot of community engagement, some resistant communities could heavily chase away our professionals. So what we learned, the 2022-2023 outbreak, we trained community health workers in conducting dignified barriers. But of course, these are heavily supervised by the professionals. What we learned from that is that once the communities get to know that maybe Kabanda is a community health worker and is part of the teams that are actually conducting the dignified barrier, they listen more to them. So that was a key lesson that we learned. But what colleagues listening in must be able to pick is that it requires an intense training to ensure that infection prevention and control is handled 100%. Of course, also to ensure that they are high-level professionals who are supporting the community health workers, who are supervising them as they undertake this work. The other critical issue which we have also learned during this, when you employ individuals to do translations for health promotion materials, of course, given the fact that health education is very, very critical in raising health literacy during outbreaks. Usually the professionals, when they translate, if you do validation at community level, you may find out that the community members are not accepting all the developed materials. So during these outbreaks, we have heavily used community health workers to validate most of the materials that have been developed by the ministry to ensure that, because they do the dissemination, we validate, and then they do the dissemination of these materials. So basically, these are some of the critical areas where we have had our community health workers during EVD response. But of course, what has been very, very key for us, the ministry undertook the development of a training manual for community health workers. We have one that is standard for routine service delivery, but also have one, a 3 days intensive training for community health workers, for them to be able to undertake mainly RCCE activities, but of course also community-based disease surveillance activities during outbreaks. So that 3 days training has been standardized, and all partners in the country who provide support basically must follow that training manual. The other critical lesson that we've also been able to pick is the intense partner coordination. Usually when there's an outbreak, most of the partners want to run to the communities. They mobilize a lot of resources and they want to run to the community. Some of them duplicate activities and some of them waste a lot of money. So if you want to be very, very effective in engaging communities geared towards controlling an outbreak or preventing an outbreak further spread. Partner coordination is very, very critical. Regular meetings with them, agreeing on which partner is going to support which activities, and of course also being very, very aggressive in the areas of monitoring and evaluation. Then the other critical area that we have also been able to pick is that for a very long time, many partners want to pay a lot of attention in biomedical, in the collection of data that's meant to provide more information in the area of biomedicals. So biomedical research is given a lot of weight, and of course, for prevention and control of an outbreak, anthropological studies are very, very critical. So, and for you to be able to collect good data that will inform you, that will give you insights the way they are at community level, you cannot run away from working with the community health workers. They have been a cornerstone to building resilient systems at that level during outbreaks. I think lastly, the other critical area which we have also been able to pick, community health workers do better if they are well facilitated during outbreaks. So you remember that our outbreak of 2022-2023 for Ebola, Uganda was able to address this within 69 days. And I'll tell you, with support from partners, we're actually paying, beyond the usual facilitation that we provide, we are paying community health workers an extra $50 per month on top of daily transport for them to be able to move to do door-to-door engagements. So for a serious outbreak, let me say serious outbreak. All outbreaks are serious, but Ebola is more life-threatening. So teams must be able to think through how to mobilize resources to be able to provide an extra incentive to the community of workers. I think for now, that's what I can be able to share with you. Thank you, and over.
Thank you very much, Dr. Kabanda, for sharing your experience and the experience of Uganda. I particularly relate to what you said about the cultural barriers, some of the beliefs, and also the pushback when it comes to dignified burials. It was the case during Ebola. Unfortunately, it's also the case for other emergencies and outbreaks. And I have in mind cholera, because I work in infodemic management, and this is something that we still see. And this is very important to take into account for our interventions. So thank you very much. I took some notes already from your intervention and also Kenya's intervention. I can really see that in both countries, one of the key takeaway is really community health workers perform better if they are protected, if they are secured, if they are heard, and also facilitated. And this is what you said during your intervention. So now I would like to bring up the experience of Ghana. And I see in the participants list that there are many people from the Ghana Health Services. So this is great. So we have the chance, we are lucky enough to have two speakers for Ghana. So I'm going to introduce Miss Gladys Gabdad Bali. She's the Community Engagement Lead for the Health Promotion Division at the Ghana Health Services. She's a Senior Public Health Officer specialized in health promotion, and she holds a Master of Public Health with Community Health Nursing background. And with her, she also has a background in social behavior change. And with her, we have Joël Aboukilia. So, Joël, you are a public health professional with expertise in RCCE and also infodemic management. And you've been working currently as a coordinator for RCC with the Health Promotion Division of the Ghana Health Services. So welcome to both of you. And for Ghana, I have one question, and I would like to ask Gladys to start with answering that question. So Ghana established a strong infodemic management system during COVID-19. What was the role of the community health workers in that system? And Was this system been adapted since COVID-19? So I'm going to start with you, Gladys.
All right. Thank you very much. And good morning and good afternoon to everyone. Yeah, so as giving a way of a background to Ghana system as far as health services is concerned, we have our system in 3 tiers, divided in 3 tiers. So taking it from the lower level, we have the district level where it's made up of the community-based services, that's the community health based planning and health services, the CHIPS, we have the health center, then we have the district hospitals. Now, when you move to the regional level, then we have the regional hospitals, the teaching hospitals also there, then the national level. So at the district level, where we have the CHIPS operating at the community level, 3 cohorts of people are considered who are very critical in the CHIPS and provision of services. We have the community health officers or community health nurses. These are people that have been trained and they are on government salary. And they provide services like maternal and child health care, preventive and health promotive services, and also as far as the emergencies are concerned, they are also there. They are also more into preventive and promotive services. Then the second cohort of people we have at that CHIPS level or the community-based level is the Community Health Management Committee members. These are community opinion leaders that they are made up from the various communities that made up the CHIPS. So they ensures that the CHIPS services are really functional. What do they do? These people also recruit volunteers to support the community health officers at the community level as they deliver their services. So the main function they do, they are able to mobilize locally available resources to help in the service delivery. For instance, if a community health officer is going for an outreach somewhere and he needs a shade, these community health management committee members can use their locally available resources and establish something like that for them to have a shade and deliver their child health and welfare clinic services. Now, when it comes to the community volunteers, these volunteers, they support the community health officers directly on the field. They do more of the community mobilization. They also are into community education. So we leverage on them because they are in the communities. They understand their languages very well. They are able to interpret the issues into the languages that people are able to understand. We use them more to support in the service provision. So now coming back to the question of their role during the COVID-19 epidemic management, because they function, they act as a liaison between the communities and the health system. So at that level, they are staying in the community, so they are able to get more of the information that is the rumor, the misinformation, things that people are not clear with. They are able to gather this information, them together with the community health management committee members. And these informations are channeled to the community health officers who are also living with them in the community. So that we have a system, we have a Kobo Collect, where the community health officer gather this information and put it on the app. Then when it gets to the dashboard, so at every level, whether regional, district level, or the national, they are able to access this application, this information for decision making. So we cannot do away with this officer. They are very key when it comes to giving feedback to the community. Maybe there have been some misinformation like COVID-19. Some people, they are using their religious to the religious affiliation not to take vaccine issues here and there. So when we get this information from them from the community level, giving feedback, we have the community information centers in the community. And community members, they feel comfortable and they oblige more when they see their leaderships in the community also being part of us, giving out information. So they join together with the community officers and they go to the community information center so that they debunk those misinformations that have gone out there. So I will leave this opportunity for my colleague Joel, who is also expecting the infodemic management to throw more light on that. Thank you very much. Joel? Yeah. Sorry. Joel.
Joel, we cannot hear you. I'm trying to see. I think there might be a problem with the connectivity. So let's wait. When he comes back, I can give him back the floor. But I think you gave a very good overview already, yeah, Gladys, about the community health system in Ghana and also their role in managing epidemics during COVID-19, but also for different health topics, because unfortunately, COVID-19 has some negative impacts also on vaccine confidence now, beyond COVID-19. So this is very important also to see how the experience during COVID-19 is also extended to other health issues. So Joel, are you here or not? Okay, so
Okay.
yeah, it looks like he will
So I
try
can,
to join
yeah,
us
it's having
a little.
challenge.
Yeah, yeah, that's
So
okay.
yeah. So for the second part of the question, if we are able to maintain or continue with the system,
Mm-hmm.
we were not able because most of the issues and the support we're having, we were getting it from our partners during the emerge of COVID-19. And now partners are no more because there is a need to provide gadgets like phones to the CHO so that you could put the Kobo collect on them and getting them data so that they could put all this information and send to the next level. So we have challenge with that. So now what we are currently we want to leverage on in our data system that we already have, the district health management information system, that the DIMS 2. So with that, there's already a system for reporting each activities from the community level to the next level. So we want to leverage on that system so that infodemic management system will be part of it. So that when the CHO is giving any reports on the services provided, there is a portion, there will be a portion of infodemic management. So that at that level, these gains will not be put down aside, but we still leverage on the structure and they could also feature and report accordingly. Thank you. Over.
Thank you very much, Gladys. And I appreciate also your transparency about the challenges to maintain some of the systems that were established during COVID-19 when the funds were available. But today, with the current funding situation, of course, we need to find and adapt to the new context and find other ways to do the same job, but differently. So thank you very much for sharing your experience here. Our last speaker now is from Tanzania. I hope, yeah, Dr. Capera, yes, you are here, I see. So, Oscar Capera, um, Oscar Capera, you are from Tanzania. Thank you very much for joining. I know that you had some issues with the connectivity before. So you are part of the Ministry of Health and you are the RCC focal point. You're a pharmacist and you're working with as the RCC coordinator in your country. So Dr. Capera, I have a question for you. So since 2023, how has Tanzania expanded the role of community health workers in surveillance and risk communication and infodemic management at community level? So, Dr. Capera, can you take over? Oh, back to you, huh? Okay, you are here.
Yeah, thank you so much, moderator. My name is Oscar Capella. I'm working with the Ministry of Health and Health Preventive Services. So under the Ministry of Health, we have health promotion services in which RCC, the risk communication and community engagement, is hosted. And one of our key priority is to invest much in the preventive services, in which the community health worker is one of the programs which we have been strengthening to ensure that we invest much in the community. So our plan is to strengthen the community health worker system and to have at least 2 community health workers per village or per hamlet and per street. So how are they obtained since the transition of the 2023, based on the lesson learned from the previous implementation? We have been developing some guidelines to ensure that we implement the integrated and coordinated community health worker system, in which it is based on the selection and the identification, in which the community health worker are being selected from their community, their localities, to ensure that they understand their locality, their community, and to ensure ownership. Also, they are being capacitated through training, 6-month training, which are divided into 2 phases. The first phase is divided into, in which they are oriented in classes, and the 3 months for the field and the practical skills. Also, they are being provided with the equipments to ensure that they are working very properly. And some of the equipments are for reporting issues, and the uniform and the other ICT equipments like phones for reporting issues. Also, apart from being trained on the 6-month training, there are some mentorship which is ongoing, and the on-job training, in which during on-job training and mentorship, they are being provided with the materials, especially the working materials, the reference material, the SBCC materials, the key message guides, the megaphones, and the other portable tools to ensure that they are conducting effective RCC and the community intervention. Also, during supervision, they are being supervised at various levels, at national level, as I have said, the Ministry of Health and the other national authority, including the PORAG. And at the regional level, there are health promotion coordinators at the regional level and the council level to ensure that they are being supervised. But at the community level, there are 2 types of supervision. There are 2 types of supervision. There are technical supervision, in which there are directly supervised by health facility in charge, in which they are being reporting. But at the administrative level, they are reporting to the either MTA or street executive officer or village executive officers. Also, during implementation, we learned that it's good to have CHW to ensure that there is a good linkage between community health facility and the other community structures and the authorities. So one of the things which have been sensitized, and it has been reported by my colleagues who have been speaking, to the issue of motivation. Also, we are motivating them to ensure that they keep the spirit of volunteerism, because one of the key need for CHW in Tanzania, it is to ensure that they are working in a voluntary basis. Although they are being motivated, but it is the voluntary spirit which we encourage much. So during 2023, we had an outbreak of MVD, and at least we are happy that through CHW, we are able to report some of these key alerts, rumors, and the other issues which are related to the public health emergency. Also, during public health emergency like cholera, we are fighting with the cholera in Tanzania. During Ebola threats from West Africa and our neighbor Uganda, we have some zoonotic diseases. CHW have been very key to report the alerts and the rumors and some of the misinformation. So during their capacitation, they are being capacitated to ensure that they conduct some basic curative services in normal, in calm phase of outbreak. But during outbreak, there are some intervention which they have to conduct, especially the RCC intervention, community mobilization and sensitization. But also part of mental health and psychosocial, they are providing the mental health and psychosocial support to the community. They are conducting the infodemic surveillance and rumor management at the community level. Also, the event-based surveillance, we are working very close with the surveillance team to ensure that we capacitate CHW to ensure that they report all alerts from the community through event-based surveillance. Also, contact tracing, it is one of the key intervention in which CHW they are doing since 2023 and before that. But also there are some issues through CHW that are being capacitated to ensure that they conduct basic health preventive services and hard to reach area, sensitization of the vaccine or immunization services. It is one of the key intervention in which there are being provided the skills to ensure that they sensitize the community to adhere to this. So there are some challenges which we think that maybe if we can address them, then CHW could be working very comfortable in the community. And one of them being motivation. We have said that yes, we are motivating them, but the way they are being conducting their intervention and the RCC intervention in the community, sometimes we find that we need to find a way to motivate them more. So we call upon some partners to ensure that we can join hands together with the government to ensure that we motivate CHW. Also to increase the funds to ensure that we are having more community health worker in the community. And since we are rolling out this integrated and the coordinated community health worker system, we are running shortage of funds to ensure that we implement or we roll out the implementation of CHW program in the country at the same time. So we are rolling it out in phases. So in conclusion, I can say that based on the experience from 2023, we have seen that the CHW has been a key actor for RCC and during public health emergency, especially during preparedness and response. Also, they do work better when they are being motivated, and you find the way they are being motivated to serve the community is very encouraging. And if we keep moving, we need to see how best you can keep on motivating them. So we call upon all partners to see how best you can invest in community health worker, a system to enhance and strengthen the community readiness. So having said this is the experience which I can share from our side, and I beg to submit, moderator. Thank you.
Thank you very much. That was very enlightening. And I really liked something that you said, that you mentioned, and you talked about the mental health also. Support that the community health workers are providing to communities. And I think this is something that is sometimes overlooked, whereas during outbreaks and even before and after, that aspect is quite critical for communities. So thank you very much for sharing your experience here. So I can see that the attendees have been very, very curious, and they shared a lot of questions actually. So I will try to go through them. So let's start with and Amarachi, I count on you also for the support if I miss anything. So I see that the first question, it's in French and English. Okay, so the first question from Hamadi Baraka. It's in French. I will translate. So and this is to all the panelists, have you made a cost analysis for the community health workers? And even if they are volunteers, how do you manage the cost also of that system? Because it still costs something. Some of you have mentioned, the transportation cost or the motivation cost. So who from the panelists would like to address this question? Yes, you can go ahead.
Yeah, thank you so much for me. What I can share an experience from us. The cost analysis, yes, we have done it, and we have some documents which maybe later on we can share with the approved document, which show how they are coordinated and integrated. Community health services are being coordinated, and the plan to sustain it. Also, it is through the joint effort between the government and the partner to ensure that we are doing this. So the sustainability and the motivation issue is based on the part of the government. Government is doing it, but also through collaboration with the partner. We are working very close with the partners to ensure that we sustain and motivate CHW wherever it is necessary or it is possible. Thank you.
Thank you very much. Going through the questions, there are actually a lot of questions related to cost, again, and especially like how in the current context of decreasing resources, how do you plan to continue those activities and to continue to motivate and remunerate also the community health workers? Because we all acknowledge here that they are critical for preparedness and outbreak response. So is someone in the panel would like to take that question? Considering the current context, what is the plan basically to continue to support financially also the community health workers? Yes, Philippe.
Thank you so much, Elodie, for the question. First of all, allow me to remind ourselves that in Kenya, I said we have two levels of governance. Each level is basically economically autonomous, and they interlink in terms of critical resources. We here currently have several sources of funding. We have the government, the exchequer appropriating funds to support the implementation of community health services. It is largely work in progress, but what has been achieved as we speak is that procurement of the kits has been done, procurement of the digital platforms for reporting, including tablets for each and every community health promoter, has been done. There are stipends that are paid for them as a way of motivating them to carry on with their duties. These stipends are paid on a 50% on a 50 by 50% arrangement between the two levels of governance. This is we see has a triple effect in terms of them delivering on their activities. But that's it and done. Remember, I also said that we have the we have the primary healthcare fund, which is part of which is part of the funds, managed by the Social Health Authority, and this also presents an opportunity for the community health services to tap in and get support. Community health services is also one of those avenues that's been recognized in the country and being used in the country to realize, universal health coverage. And through this, then, of course, we anticipate support coming through. So alongside the civil societies and the partners and stakeholders that are supporting the Ministry of Health, we largely see things working. But like I said, sustainability is still a big question because, dependent partners have their funding circles. Some of these programs have their lifelines. and over dependence on them then means when they end, then we are left hanging. So sustainability is really a question that we have to think through.
Thank you very much, Philippe. Oh, I see a lot of hands actually. Joel, do you want to take that question too? Over to you.
Yes, please. Yeah. So thank you very much for the opportunity. And sorry I had to drop off along the way. Just to add on in terms of sustainability and then how we are working with the community health workers. So realize that we have there in like three tier. So you have the community health nurses who are actually employed and what the government is looking at now is to see how we can that is being collected for individuals to help in terms of health financing. So services. So there is an argument currently in Ghana trying to see how we can be able to leverage on that fund to pay for the primary health services, which includes some of the services that the community health workers do provide. So once that one to kind of reimburse for their transport in terms of the home visits that they kind of embark on. So there'll be a sustained kind of funding for them to be able to ensure that that one has been done. The second one that I want to talk about has to do with collaboration. And we have been working closely with our One Health partners and then other partners who are also involved in risk communication and their community health activities. So take, for example, Red Cross that has a lot of volunteers in our communities. So we have leverage on collaboration to see how we have been able, to see how we can be able to leverage on their volunteers that they already have because they have a very good working relationship with them. So where normally we shortfall in terms of not getting funding to kind of expand our activities to reach volunteers in terms of what we call emergency response, or work collaboratively with them to see how we can be able to tool them with the materials and then the skill that they need so that they do the community engagement activities for us, so that in the event that we also get some support, then we can be able to expand and then reach other areas that the community health volunteers were not able to reach. So that is what I can share from Ghana. Thank you, and over.
Thank you very much. Gladys, would you like to add something?
Yes, please. So to add on to what my colleague Joel said, in order not to distort our structure of functionality in terms of service delivery, and we already have some volunteers that they are supporting our CHIPS concepts at the community level, as I mentioned earlier on. So we are advocating more of the non-monetary motivation that is more sustainable, because we realized that in the emergence of COVID-19, when partners were there, they were being motivated financially, so they were doing a lot. Now they were not there, so that enthusiasm may fall. But in our routine services, they are all also there for us in the communities across the various CHIPS compounds or CHIPS zones. So we are advocating for support for their motivation, which is the non-monetary. For instance, if we get, we've done some survey about their package of what they really want. So if a volunteer that is supporting a health worker who is being paid by government, is on government salary, and for this volunteer, it doesn't have anybody, by just out of voluntary services providing, they're advocating for something like a motorbike or a bicycle that it will enable them to go out to the next community to mobilize people for the next section of whatever intervention we are coming to put across as far as emergencies are concerned. Likewise, the community health management committee members. So we are looking at a more louder package of motivation other than the funding. So if you are able to provide them with bicycle, they will not buy any fuel. They could use it to ride and move around the community and also assist in the education as far as the race communication is concerned. So we are using also this platform. We know we have partners on this platform to come to our aid so that we can motivate our volunteers. Although we are leveraging on other partners, volunteers, like as Joel said, on the Red Cross people, but we have volunteers we are already working with at the various shape zones, and we cannot do away with them because they are supporting our routine services as well. So we need to bring them together on board so that in terms of emergencies, they will also have a role to play, as they always do. Thank you, Onova.
Thank you very much, Gladys. Oscar, I see your hand is up. Would you like to add something?
Yeah, thank you so much for the contribution. And to add on what my colleagues have said, we are also advocating for monetary and the non-monetary motivation, and you used to do it even before this coordinated program. But also we are leveraging the resources from the partners, coordinating the program, because there are various programs which are using community health worker. They have various funds. So we are motivating them, we are coordinating them, we are ensuring that the integration or the use of CHW is being coordinated well, so that we mobilize and leverage the use of the resources. Also, we used it to do the advocacy session to these high level officials and some of people who are being engaged in planning issues. We are advocating to use their internal resources to ensure that they sustain through their plans. And one of the strategies which we are using to ensure that we sustain this program is to ensure that we advocate for the use of internal resources, their own resources from the facility, from the community, from the council level, so that they can keep on planning from their own resources rather than depending on the partners. So for current, we are coordinating them, but for long-term outcome, we are advocating to use the internal resources to sustain the process. Yes.
Thank you very much to all of you for addressing this very critical question about resources, coordination. I've heard that as a solution also, because we may not have one agency or one ministry may not have all the resources to support the community health workers, but with coordination and understanding who has what and who does what, that could be also an avenue for sustaining and being better prepared also before the outbreak, because unfortunately this is also where the money is usually during crisis, but the key work happens way before the outbreak. So thank you very much. There is another question from Emilia, and this question is meant for Ghana, but it's actually a question that is valid for all the countries here. And considering that now, so we all acknowledge that community health workers are really important. And you mentioned the different roles that community health workers are fulfilling. There's a higher pressure for them to do more and to expand their skill sets. You talked about capacity building. So the question is, how has the education of community health workers changed to match the current demands of emergency preparedness and emergency response? So who would like to take that question? How do you support them with capacity building and education for them to be able to fulfill those multiple roles that they have?
So maybe I can start.
Yes, you can start, and then I will go to Joël. Yes, please start.
Yeah. Thank you so much. To ensure that they are doing this multiple work very properly, we do the capacity building, the orientation, and yes, I have said that we have been supervising them at the national level, regional level, council level, and at the community level, in which they have been getting the technical assistance from health facility in charge, whom they are being reporting or from their locality. So they have been receiving technical support from health facility in charge and the other health experts from the community, nearby health facility, also the regular supervision and the mentorship. So wherever there is an outbreak, we do call them, capacitate them, and equip them with knowledge and skills to ensure that they are ready to tackle that outbreak which is there. But continuously, health facility in charge is doing the great job to ensure that they are sustained with knowledge. Thank you.
Thank you very much, Oscar. Joel, over to you.
Yeah, so thank you very much. So in terms of capacity, I think we have the facilitation, how to move around. So maybe I'll just talk in terms of the skill set. So we have also tried as much as possible to ensure that with the lessons that we actually learned from COVID, where actually we thought our, what do you call it, officers on the ground knew everything about COVID, but it showed that as the situation evolved, there were some gaps in terms of skill and the information that they needed to be effectively engage community members. So based on that, what we have done is that as and when a particular emergency starts, we make sure that the community health officers or workers are well oriented on it. They have all the questions that they need in terms of doubts communicating to the communities. So that is what we have done. So on emergency, even though we have our standard operating procedures as to how they should do risk communication surveillance in the event of an emergency, we have made it a conscious effort that depending on a particular emergency that evolves. So for instance, if it's Mpox, we try to ensure that they are oriented very well on Mpox. If it's cholera too, we take time to take them through cholera. So they ask all the questions that they need, and then they can be able to, engage communities alongside. So that is what I want to add. Thank you, Novo.
Thank you very much, Joel. Philip, you have your hands up. Over to you.
Yeah, thanks. I think we share a lot in common with the previous panelists who've spoken, but I just want to add that for Kenya, deliberately we developed a curriculum for training, building the capacities of this community health workforce. The curriculum has a number of modules depending on the work that is expected of them, and the content of the curriculum is tailored, scaled down to meet their level of understanding and the outputs that are expected of them. So there will be basic modules, there will be program-specific modules, and we also have other surveillance modules as well. And to make sure that they continuously or they apply the skills appropriately. They are closely supervised by another layer of supervisors that are called the community health assistants. These are the community supervisors. And every time the worker, monthly, they meet, to refresh the community health promoters and also to address issues that are challenges that are emanating from their day-to-day activities. Yeah.
Thank you. Thank you very much. I think there is only one question left that I see in the Q&A. Amarachi, if I missed something, please let me know. And this is addressed to Ghana. I think there are a few people who are asking for more information about how community health workers manage infodemics, especially in hard-to-reach communities. And also there were some questions about the Kobo Collect system that you're using and how the data you're collecting basically feed into the community feedback loop that you described, Gladys. So you want to take that question, Gladys?
Thank you very much for the question. So how they manage infodemics in the hard to reach areas. We also have a system community scoring, where the community leadership, that's the community health management committee members, they meet quarterly to score the community, the CHIPS services that is being provided at that particular zone. So in the scoring, they also have a portion where rumors or misinformation they've heard gathered from the community members, they bring that one also on board where the health workers are, so that they sit together and look at how best these rumors or the misinformation could be gathered. So that place also is a form of gathering information that is given to the health worker that puts on the dashboard. As I mentioned earlier, during the merge of COVID-19, we were able to use the Kobo Collect to gather this information to the dashboard for the next level for decision making. But then now that it's no more, we are trying to put it back, because these people from the hard to reach, they are also using the DIMS tool to report every routine activity that they do into our data system. So we want to leverage on that platform so that we'll have a portion of infodemic management reporting system that whenever they are reporting their routine services monthly, they could also gather this information and report accordingly with the hard to reach areas. Over. My colleague Joel is there. You want to add on?
Yes, please, Joel.
All right, so thank you very much. I just want to be specific so that maybe we know the flow. So for instance, community health workers are involved in infodemic for the country. And what we have done is that in terms of data mining, we have segmented the levels. So the community health, so the community health workers, we have actually assigned some data sources to them. That is happening at the community level and then reported. So for those who are not literate in terms of using phones where we use the Kobo collect information. They report it actually by word of mouth to the community health nurses, who then input the information in a rumor log that we use Kobo collect to develop. So that is what they do. So they will have allowed them only to do the monitoring So where we have responses to give to the various rumors, we give the feedback through our reporting or how we do the community health workers for them to engage communities. So the information that normally we get through Kobo Collect, normally we download it to Excel. We kind of clean the data, and then we use Power BI. That is where we use in doing the visualizations using the dashboard. So the dashboard, normally you can actually even drill down to a particular district or a particular community to find out the particular rumor that is pertaining around that area. And that gives you a targeted intervention for you to go so that you do not develop more like a one cap fits all, what you call intervention to do. But the dashboard gives you that information for you to be targeted in terms of your strategy and then the type of channels that you may use to be able to reach the community members. So that is how the community health workers are helping us. And I think that we have spoken a lot about their importance because they are the ones who are with the community members and then they provide. And I think Gladys has already mentioned one of the key challenges that we have had. And then what we are trying to do is that we are trying to leverage on DIMS. DIMS is what the Ghana Health Service is using to collect data or transactional data from all the levels, from the community level. So we are trying to use that same method too, because already at that level, they have the digital tools that they are collecting information, where we want to offload the Kobo Collect or the rumor log also on those tools, so that once we offload it, we'll have a wider, coverage in terms of those who will report in the rumors. And then we can now build a separate dashboard on the DIMS, which will give us information on the infodemics that we can be able to use to take decisions and then to give responses back to the community health workers for them to engage communities. Thank you, and over.
Thank you so much, Joel, for those clarifications and that level of detail. That's very, very interesting. And obviously, I'm biased, but I really like also the message about leveraging resources and skills, because the problem is too big for one person, for one agency, for one ministry. So there is no other choice actually than coordinating and working together on that. I'm going to conclude actually this first panel by saying few words. These are my takeaways from this amazing panel, and really, I really like all the different angles that you shared with us today, and I really appreciate your transparency also about some of the challenges and the doubts that we may have about the future. So the first question when Amarachi opened this panel was, how would you describe community health workers? And to me, the word that comes to my mind is superheroes. They are truly superheroes. We're asking a lot from them. They are at the front line during outbreaks, and some of them with a very high case fatality rate, very scary ones. So I think and what you have been sharing from your different countries is how you have been able to support them, to capacitate them, to value them, and also to really work with them to achieve the universal health coverage, but also response, control, outbreaks. We are asking a lot also from them to become now epidemiologists, almost very strong communicators, now infodemic managers, so many things. So it's very important also that we hear from you on how you have been successfully able to do that. So this is really great. And I think for the future, the threats are multifaceted. There is a growing distrust, unfortunately, on science and also on public health responses. So the community health workers are our voices, are our faces. So it's extremely important, again, that we value their work and support them. So on those words, I'm going to hand over to Amarachi for the transition to the second panel. Thank you very much.
Thank you so much, Elodie. Thank you for managing such a rich panel. We learned a lot from this panel of speakers. Thank you to the countries for sharing your experience with us. Before we transition to the next panel, may we do a bit of Slido on what we have just heard from the countries. So you can also tell us what you think the most important skill a community health worker or the community health workforce needs during an outbreak. And while you are scanning the code on your far left, Aditi is also going to put the link in the chat for those of us who cannot scan. Maybe start getting your responses. What do you think is the most important skill a community health worker or the community health workforce needs during a public health emergency or an outbreak? Colleagues, we're waiting on your responses. And while we're waiting for that, may I encourage the second panel to start getting ready? Yes. Yes, colleagues, can we have your responses for building resilient building resilient communities? What do you think is the most important skill a community health worker or the community health workforce needs during a public health emergency, an outbreak? It can be an epidemic or a pandemic. Colleagues, you can scan the code at your far left or far right, and then we can have your responses. Somebody said patients. Great. Diagnostic clinic. Clinical diagnosis, I don't know. Communication skills, I think that that's super important. Empathy and trust. Communication skills is popping up more. That's why you see it bigger on the screen. We have about 2 minutes to close this session, colleagues. Yes, they should be able to suspect a possible threat. So surveillance skills. Great. All right. Do we have your responses? I can see communication, timely communication. I think we all agree that communication is a huge part of the skills that a community health workforce needs. Great. Infodemic management skills. That's really good. Okay. Let's move on to the next question. We're asking, what is one word that currently describes the current describes the current policy environment for the community health workforce in your country? What is one word that describes the current policy environment for community health workers or the workforce in general in your country? I can see that a few colleagues are typing. Oh, somebody says they're undervalued. Personal safety and IPV. I don't know if that's IPV or IPC. All right. Okay. One word that describes the current policy environment. Somebody says dedication. And I think that that's super important. All right. In front, I'm thinking that person is saying they're neglected. They're underutilized. Yep. Okay. They're champions. All right. Great. Okay. Colleagues, you can keep sending in your answers as we transition to the next panel. On this panel, the panel is from margins to mainstream. We're going to be talking about institutionalization of the community health workforce in the national emergency system. And for this panel, we're going to have Dr. Julianne Anoko as our moderator. She's the RCCE lead for health emergency preparedness and response in the WHO African region. She's a senior anthropologist and a public health specialist that has been responding and preparing countries to respond to outbreaks for the last 20 years. Over to you, Dr. Julian.
Merci beaucoup, Amarachi. Je vais parler en français pendant ce panel. Donc, notre panel, ce deuxième panel, va porter sur de la marginalité à l'intégration.
Apologies, Dr. Julian. May I just interject for a bit? Colleagues, this session is going to be in French. So for our English-speaking colleagues, please go into your interpretation booth and click on English. And you can also mute original audio so that you only hear the interpreted content. Please go to the interpretation button at the bottom of your screen. Click on it. It's going to give you several options. You can pick English and then you mute original audio so that you can only hear the interpreted content. Apologies, Dr. Julian, over to you.
Merci beaucoup, Amarachi, et bravo aux panélistes de la
Thank you very much, Amarachi, and to all the panelists for this session. This session
is
will
going to
focus
be
on
from the
nationalization and
margin to
integration.
mainstreaming. How do countries institutionalize public community health workers in emergency situations? Though these agents are the first to be called in emergency situations, however, some countries have made programs in the standardization, the funding, and the extension of community health workers within EPRs. During this session, we're going to listen to Francophone, to French-speaking countries to see how they integrate or mainstream community health workers in their strategies, policies, and national coordination structures. We're going to suggest them to share their experience concerning policy development, funding mechanism, and the way the institutionalization of community health workers has improved the country's capacity to handle emergency situations. For this panel, we have three countries. We have Madagascar, Senegal, Mali, which are going to share their experiences. I am going to call on Madagascar with Dr. Rambiana Solo. Dr. Henry is a medical doctor. He is in charge. He is in charge of responsibility in the Ministry of Health. Dr. Henry, please, I wish to know which are the major measures that Madagascar have taken for the past 2 years to standardize the role of community health workers in the face of emergency situations. Dr. Henry, you have the floor. Thank you.
Vous m'entendez?
Can you listen? Can you hear me? 5 on 5, doctor. We can get you and we can see you on our screen. Thank you. Thank you, Mrs. Facilitator, for giving me the floor. And good morning to all the participants who are all connected. It is a pleasure for me to take the floor in your midst. And I am speaking from Madagascar to share experience. And the moderator said, I am a doctor and I am in charge of health services in the Ministry of Health. That is the head direction for community workers in the country. And it gladdens me to share experience in Madagascar concerning the role of community health workers in the face of emergency situations. Community health workers in Madagascar play a very important role, and this is the fourth pillar of our health pyramid, at the community level, the health level, just to name a few.
Selon le dernier recensement de 2024,
according to information from 2024, we worked with more than 50,000 community health workers in Madagascar. We adopted a participatory approach rather. But like our colleagues from Africa, from all the African countries, as they share, the status of community health workers in Madagascar is unfortunately still considered as volunteers. And this is a major challenge for the sustainability of the commitment within our system. For the moment, they are motivated and they are trained thanks to the support of technical and financial partners, especially in the health domain in our country. The training focuses on three phases. Everything related to promotion, sensitization. We have an essential package, especially regarding maternal diseases. We have all the packages related to activities that request a punctual, a specific training rather.
La préparation aux réponses, la préparation nationale aux situations d'urgence effectué
The
par les
national
agents
preparedness
communautaires
to emergency
fait partie des paquets d'activités spécifiques chez nous, ici à Madagascar.
is part of our
Donc, pour
packages
répondre à
in
votre
Madagascar.
question, quelles mesures
So
clés
to answer
Madagascar
your
a-t-il pris au
question,
cours des 2
which are
dernières
the
années
major
pour
measures that
officialiser et
Madagascar
adapter les agents
have
communautaires
taken
dans
to
la préparation
standardize
nationale
the role
aux
of community
situations
health
d'urgence?
workers in the face of
Comme les autres pays
emergency at the
africains aussi,
national level?
Madagascar
Like other
intervient
African countries,
nous faisons face
Madagascar
à de nombreux défis liés aux
faces a
urgences
number of
sanitaires et
hurdles
catastrophes naturelles.
related
Nous sommes
to
conscients que les
health
agents communautaires
requirements.
représentent un
We
levier
know that
stratégique indispensable pour faire face à
we
ces
know that
situations
we have
de
specific
manière
needs and
anticipée
we
et
need
efficace.
to overcome
Des agents
these
communautaires
challenges, and by so
participent
doing, we
depuis la
must be
préparation et la prévention
efficient. Community
jusqu'à
health workers participate
l'assistance
in
à
a
la
couple of
gestion des
activities.
catastrophes
There
sanitaires.
is a preparation, prevention
Donc, il nous
to
appartient de
the
renforcer
management of disasters.
leur reconnaissance, leur formation et leur intégration
In
afin d'avoir un système résilient
in an
inclus et durable.
acknowledgement report,
Docteur,
we had
docteur Henri,
information.
docteur Henri, donnez-moi
Oui,
juste
oui,
une petite
Dr.
minute.
Henri,
Je voudrais juste
oui.
que vous
please
nous
give
ameniez
me a
vraiment sur ces
moment.
mesures
We
officielles,
wish you
les
to
mesures
give
on
us
a pris pour officialiser leur
official
rôle au Canada.
measures that
On sait
were
que Madagascar a fait
implemented
beaucoup
to
de choses.
standardize
S'il vous plaît,
the
merci
role.
beaucoup.
We are aware
OK,
of the
OK.
importance of
Formaliser
Madagascar
et
in this domain
pérenniser les rôles
to
des agents
standardize
communautaires.
and
Nous
sustain
avons
the work of community
actualisé,
health
par exemple,
workers.
notre
We
politique
have
nationale en
updated
2017
our
et nous avons élaboré deux
national
guides
tags.
opérationnels,
We have
les guides PAC,
worked on two operational guides
qui stipulent que les agents communautaires peuvent faire
which states
dans les sites
that
communautaires
community
et
health
les guides
workers,
harmonisés, guides de mise en œuvre harmonisés qui harmonisent
well,
les
we had
interventions
a
de tous les
guide, a
partenaires
harmonization guide,
œuvrant dans les
which
santé communautaires.
harmonizes all the activities
Et
of
en
community health
2023,
workers. In
nous
2023,
élaborons et validons ensemble avec le partenaire
we
technico-financier
developed and
une feuille de route
validated
nationale sur
with our technical and
demander
financial
l'engagement
partners,
de tous les partenaires techniques
and
et financiers œuvrant
we
dans la
equally
santé
proceeded
communautaire
by
ici à Madagascar.
asking our other
Pour
partners
nous, l'institutionnalisation passe par la
to be
vulgarisation des
engaged.
rôles des
Our
AG et
institutionalization
leur
is
intégration
done
dans le
by the
système
mainstreaming and the
d'énergie.
integration
C'est le quatrième pilier de
of these
notre pyramide
agents
sanitaire
the
et surtout la reconnaissance de leur
in
contribution.
our health pyramid
Mais comme j'ai
concerning
expliqué
the
tout à l'heure aussi,
contributions, like I
nous
rightly
sollicitons
mentioned.
le partenaire technique et financier
We are
de
calling on our
participer à
technical
la
and
motivation
financial partners
de nos
to
agents
take part
communautaires.
in the incentiveness of
Euh,
our community health workers.
Nous sommes conscients que l'agent communautaire constitue une ressource précieuse et
We
incontournable dans
know that
notre
our community health
stratégie
workers
et
play
préparation
a
aux
great
urgences.
role, especially in the development of
Et pour être
our
bref,
strategies regarding emergencies. In short,
ainsi s'achève mon intervention et je suis disponible pour répondre à toute
in a
question.
nutshell,
Merci
rather,
beaucoup.
these are a
Merci
couple
beaucoup,
of
docteur
measures that are
Henri
taken by
Rambiarasolo,
Madagascar, and I am
pour
open to
d'avoir
any other
partagé cette
contribution.
expérience de
Thank you, Dr.
Madagascar.
Henri, for
Ce que je
sharing
vais
your
retenir ici est
experience
que
from
les agents de
a
santé sont
Madagascar
encore
point of view.
des
What I'm
bénévoles
going to
et
say
des
here
volontaires, ce qui est vraiment un grand défi pour leur pérennisation. Et la
is
plus
that
importante
we
chose
are
que vous
dealing
avez
with
dit par rapport
volunteers, which is a
à
challenge
l'officialisation et l'institutionnalisation, c'est qu'il y a une politique nationale qui a été
concerning
développée en 2017
mainstreaming and
et on a
institutionalization
aussi
is that there
élaboré
is a
deux guides
national
PAC
policy that was
qui
developed
sont
in
vraiment des guides qui
the
harmonisent les
1990s,
interventions
and
des agents de
we
santé
have
communautaire,
another
mais aussi
pact
pour que tous les partenaires techniques et tous les autres secteurs puissent s'aligner sur cette politique-là et sur ces deux guides-là. et aussi la feuille de route qui a été validée hein, au niveau
In
national.
addition, we have a roadmap that has been validated at the national level and enables us to have some sort of harmonization program with community health workers. And we equally call on our financial and technical partners to keep supporting us for a very good work. Thank you very much, Dr. Henry, for your intervention. We're going to have questions subsequently that we're going to write in the chat box.
Pour mieux comprendre la situation de Madagascar.
And we count on you for the QA sessions. Thank you, Doctor. Right away, I am going to call the attention of Senegal. Senegal is represented by Mr. Biram Cham. Mr. Birai Cham is an advisor in community health. He is the lead of the monitoring and evaluation unit.
Donc, Monsieur Birahim Cham, je vais vous souhaiter la très bienvenue à ce panel.
Mr. Birahim Cham, you're welcome. You're welcome to this panel. And we thank all the other panelists for preparing a paper.
Mais aussi ces interventions qui sont vraiment des interventions en vif. And
we equally thank you because you do not only prepare a paper, but you share insights with us. Doctor, please, I have a question for you. I hope you're connected. Sir, please, how has Senegal ensured progress, the progress of its strategy in terms of financing for the community health workers since 2023. We know that Senegal has expertise in this domain, but how did you go about handling funding? Thank you, Mr. Biyarim, and thank you for sharing experience with us. You have the floor. Thank you, ma'am. Good morning, everyone. Thank you for giving me the opportunity. It is an honor. I hope you can get me crystal clear. Yes, sir. We can get you 5 on 5.
Ok, merci. Merci pour la question. Donc, juste dire que, faire un petit rappel, hein, pour dire qu'au Sénégal, quand même,
may I just recall that in Senegal, the community health workers play an important role in our community. We can find them at every level. Since 2013, Senegal has institutionalized community health through the development of policies, community health policies. Right now, we have 2 strategic plans at the national level, community health, which has been developed. And in these, we have community health workers who play a main role, who are at the heart of our activities. Right now, within the framework of the institutionalization of this aspect, we are working on the co-construction of a new strategy, and we have a new national strategic plan at the community level, which ensures the success of the activities of community health workers. Now, at the national mapping sector, there is a strategy that has been established as well. The interpreter lost the speaker.
Monsieur Biram, j'ai l'impression qu'on vous a perdu.
Sir, unfortunately, it seems like we lost you. Perhaps you may want to turn off your camera to ensure your audio to be clear. Sir, please, if you can get us, can you please turn off your camera to ensure a better bandwidth? Yes, I can get you.
Merci beaucoup. Comme ça, vous enlevez la vidéo et on aura une meilleure bande passante pour mieux vous écouter.
All right, sir. So as you turn off your camera, we're going to have a better bandwidth. Thank you. I was saying that right now we have a mapping which is ongoing. And it is going to update the number of community health workers we have right now. We have more than 7,000 community centers in Senegal. In Senegal, community health workers are volunteers, and they really take part in the implementation of community health activities. Concerning the standardization, in Senegal, we have two categories of community health workers. We have care health workers, which are the AC, which are the ASC. We equally have the prevention community health workers. We have traditional medicine practitioners, and concerning their training, community health workers are trained in Senegal under a given package. We have a basic package, which revolves under action and promotion sensitization as well, and communication on the risk of some diseases. They are equally trained on some community aspects. In addition, we have another service package under which we train public health actors. The epidemiological situation in Senegal is handled as per priorities. We have major health situations or conditions. And concerning funding, let's just say that the process is ongoing. We are developing a project regarding this aspect. We have highlighted a couple of challenges as well. To enable the formal identification, the integration, and to ensure the standardization within the health system in Senegal. Like I said, the process is ongoing. We have the mapping of these, the mapping or the mainstreaming of these community health workers. Right now, we can't integrate ourselves in the national system. So considering the health pyramid, that is the situation. So we are working hand in glove to ensure that all these community health workers can find themselves on these packages that I just mentioned. Each time we have to proceed to a recycling procedure. Another challenge is access to funding. And to conclude, may I just say that we must recognize the role that these actors are playing, given that they occupy a major role in our health system. Community actors to perform the duties as expected, we call on technical and financial partners to take action and to proceed to supporting us. Thank you.
On avait un peu de petits soucis pour vous entendre à un moment.
Yes, sir. At some point, we faced challenges listening to you. I hope that your internet is much more stable, and I wish you to be more audible, please. Thank you. So I was talking about funding-related issues. We really need our financial and technical partners to garner resources for us to take action as expected from us. We equally call on the implementation of national strategies. I think we're going to better our activities if we really integrate and institutionalize our community health workers, because the expertise is really valuable in our activities, and they are really committed to our common cause. In a nutshell, may I just say that Senegal is working slowly but surely, steadily, most especially in the achievement of our objectives. So let's work on the symbolic valorization of our community health workers, and let's recognize that these individuals occupy an important role in our community. So this is what I could say as per the question that was asked to me.
Merci beaucoup, Dr. Birahim Cham, malgré les défis. Et on est heureux de savoir que vous aviez
Thank you.
prévu votre téléphone
In
au
spite
cas
of
où
the
la
challenges you
connexion de votre
faced
ordinateur ne marchait pas.
regarding the
Merci vraiment d'avoir
implementation
été
of
très
your
aimant par rapport à ça.
activities.
J'ai retenu deux grandes idées. Le Sénégal a initié une politique d'institutionnalisation des agents de santé communautaire. Ils ont fait déjà deux plans de travail,
They
qui sont des plans quinquennaux,
put in
mais
place
ils sont encore en
2
train de
5-year plans,
remettre à jour la
and they are
cartographie, par
still
exemple, mais aussi la
putting
question des
in place the
financements, la question de la
cartography and
géolocalisation pour vraiment savoir comment
geolocalization and
rejoindre les agents de
financing
santé
issues
communautaire,
in order to
mais aussi
locate
quelles
exactly
sont
where
d'autres
the
sources et d'autres opportunités de financement
community health
en
service
dehors des
providers
financements
are
de l'État, parce que
located.
jusqu'à présent, les
And
agents de
they are
santé
working,
communautaire, tout comme le
not taking
système
into
santé, est financé
consideration
par
the
le gouvernement
finances
fédéral.
provided by
Et
the state.
aussi, vous êtes en train de travailler
And
pour
you
les
equally
élus locaux,
said you
les
are
élus locaux comme les
working
maires,
for
les sous-préfets,
the locally
tous ces
voted
gens-là
people,
puissent
like
s'investir
mayors,
avec des fonds locaux
should
aussi
be
à valoriser les
able
agents
to
de santé
take part
communautaire
in
qui donnent
this
des résultats
initiative in
pour que
order
ces élus locaux
to
puissent même
support
participer à des campagnes
these
électorales avec des
community health
résultats.
service
Ils ont
providers
aussi les
in order to
bénéfices du travail des
obtain
agents de
results
santé communautaire.
for them to
Et
be
vous
able
avez aussi
to
dit que
profit from the
je pense
initiative.
parmi les gros défis que je retiens,
We
le
equally
plus grand
said that
défi ici, c'est
what
aussi
is
la
lacking
coordination pour qu'on
is
puisse vraiment
coordination,
reconnaître le
for us
rôle
to
des
be able
différentes
to
structures
acknowledge
des agents de
the
santé communautaire
role
dans
of
l'ensemble du système de
the
santé du
backbone
Sénégal,
of
mais
the
aussi du développement
whole
du Sénégal
health
dans son
system
ensemble.
together
Donc,
with
merci beaucoup,
the
Monsieur Birahim
Senegalese
Thiam.
government. Thank you very
Je
much,
vais
Mr.
voir,
Ibrahim
est-ce que
Tian.
notre collègue du Mali, il est là?
Is
Donc,
our
pour
colleague
le
from
Mali,
Mali around?
nous avons
So
Dr.
as for
Youssouf
Mali,
Koulibaly. Dr.
we
Youssouf
have
Koulibaly, j'espère
Mr.
que vous êtes
Yusuf
connecté
Koulibaly.
dans ce
I hope,
panel.
Doctor,
Je
you
l'espère
that you
bien.
are connected in
Si vous
this
êtes là, est-ce que vous pouvez
panel.
lever la main pour qu'on
If
puisse
you are there, please
nous
can you raise
rassurer que
your
vous êtes là
electronic
et
hand
on pourra vous
for us to
donner
be sure
la
that you are
parole par la
around
suite.
and give you the floor
Donc,
immediately.
Dr. Youssouf Koulibaly est le
Dr. Yusuf
sous-directeur des
Koulibaly
établissements
is
sanitaires,
the
de la réglementation et de la
director
santé communautaire au ministère de la Santé du Mali. Merci beaucoup.
for
Donc, Dr.
community
Youssouf
health
Koulibaly
services
est le
in
ministre de
the
Santé publique et
Ministry
cadre
of
supérieur
Health
de la
in
santé.
Mali.
Il a plus de 25 ans
He is
d'expérience dans
a
le
high
domaine de la santé
authority,
communautaire et la
accumulating
régulation des
25 years
prestations
of
de santé au Mali.
seniority
Dr.
in
Koulibaly a utilisé
community
plusieurs
health services in
initiatives en
Mali.
matière d'engagement
He
communautaire
led a
et
lot
il a
of
contribué
initiatives in
à
community health
l'élaboration et au
and
suivi
he worked
des
towards
stratégies
the
d'engagement et de
elaboration
prestations
and the
de services
monitoring
au
of
niveau
national
communautaire.
strategies and
Dr. Koulibaly, voici ma
distribution of
question pour vous.
services in Mali.
Le Mali fait
This is my
partie
question for you,
des
Dr.
rares pays
Koulibaly.
à avoir
Mali is
intégré.
one of the rare countries to have.
Dr. Koulibaly, est-ce que vous êtes dans l'appel?
Dr. Koulibaly, please, are you with us?
J'ai l'impression que Dr. Koulibaly n'est pas connecté. Il était
I have the
prévu que
impression that
je
Dr.
ne sais pas s'il
Koulibaly
a des
is
problèmes
not
de
around,
connexion.
but I saw him connected at some point. I don't know
En
if
ce
he has
moment, on ne le
connectivity
voit pas
issues.
connecté.
Presently,
Sa
we can't
connexion a
see him
subi d'être
online.
interrompue,
Maybe his
comme il
connection
arrive souvent.
was being interrupted,
Oui, c'est les problèmes
as
du direct.
it usually
Dr.
happens.
Youssouf Koulibaly, vous
That
nous
is what
entendez?
happens when we are live.
Ah, est-ce que vous pourrez
Oh,
peut-être
Dr.
nous envoyer
Koulibaly,
un
you're
message,
around.
s'il vous plaît?
Please Can you speak louder? Yes, I can hear you. Thank you. I was preparing to ask you my question for you to shed more light on the experience of Mali, which is one of the rare countries to have integrated community health service providers in their political.
Ok, merci.
On aimerait savoir, donnez-moi une minute, je vais
The
terminer
interpreter
avec
can
ça,
hear
s'il
the
vous plaît.
floor.
Donc ici, nous aimerions savoir comment
So
est-ce que
we
cela a
have
été
somebody speaking.
réalisé et dans
One
quel
of the
délai
participants' microphone
le
is
Mali a pu
open.
développer, intégrer
How was
ce modèle de
Mali
santé
able
sanitaire dans leur politique
to
nationale.
include
À vous, monsieur
how
Dr.
was
Youssef,
Mali able to
à vous.
include the community health service
Nous
providers
vous
into
écoutons.
their
Vous pouvez prendre la
projects?
parole,
Thank
s'il
you.
vous plaît. Vous nous entendez, Dr. Youssouf Koulibaly?
Can you hear me, Dr. Koulibaly?
Je pense que nous avons encore un défi de connexion.
I
Donc,
think we still have
qui n'est plus
connectivity issues. I can't see online. I can't
Alors, ce que
see
je vais
him online
proposer,
again. So
en
my
attendant
suggestion
que
is,
Dr. Koulibaly revienne,
while
donc je pense
waiting
que
Dr.
Amarachi,
Koulibaly,
nous allons peut-être
Amarachi,
entrevoir dans
you
ces questions
can
pour
go
pouvoir
and look
prendre quelques questions en
at the
attendant le
questions
retour
in the chat
de Dr.
while
Koulibaly.
waiting
On va
Dr.
prendre quelques
Koulibaly.
questions qui auraient pu
We will be
être
taking some
adressées
questions in
au
the chat
Sénégal et puis à
addressed
Madagascar. Est-ce
to
qu'on peut regarder
Senegal and
ces
Madagascar.
questions, s'il vous plaît,
Please,
pour
can we
voir
look
si
at
nous
some of those
pouvons y
questions
prendre quelques questions et
to find out if
répondre?
we can reply and provide some answers to those questions?
Donnez-moi, je vais essayer de voir le...
Absolutely,
Please,
Dr.
2 minutes, please.
Allez-y, Amarachi, merci beaucoup.
Go on, Amarachi.
Absolutely, Dr. Julian. We have some questions, but I'd leave you to look at the French questions in the Q&A while I also go to the chat and check for some questions. Colleagues, please put your questions in the Q&A, not in the chat, because we're not able to monitor the questions in the chat. There's a question in the chat, Dr. Julian. Somebody just put a question in the chat, not the Q&A, the chat, from Amy Mbak. Have you seen that?
Merci beaucoup, Madame Amim Baké. Je vois que vous avez posé une question.
Thank you very
qui
much,
s'adresse,
Madame
à
Alim
Monsieur Ibrahim
Bake.
Thiam
I
du
think this
Sénégal.
question is addressed to Mr. Birahim
Dites
Thiam
qu'il faut
from
juste
Senegal.
préciser
You
que le
say that
Sénégal
we have
a
to specify
partiellement
that
intégré
Senegal
les
partially
infrastructures
integrated
sanitaires, les infrastructures communautaires
health
entre
facilities,
les
or
cases de
rather
santé
community
et sites
facilities, such
communautaires
as
dans la pyramide
health
sanitaire du Santé
centers
public. Je
in
pense que c'est
the
juste
sanitary
un ajout
pyramid since
d'information
2018. I
et
think
un
it's just
commentaire
a contribution
que
and a
une
comment
question en soi.
rather
Monsieur Thiam,
than
je ne sais
a
pas si vous
question.
aimeriez
Mr.
commenter
Tiam, I
par
don't know
rapport à
if you would like
cette
to chip
suggestion et cet
in
ajout
something
d'information que
regarding
nous a
this
apporté Madame
suggestion
Amine Baké. À vous,
from Madame
allez-y,
Ami
Monsieur.
Bake.
Merci, merci.
Over
C'est
to you, Mr.
l'occasion aussi pour
Tiam.
moi de
Thank you.
remercier
This
Madame
is
Amin
an
Baké pour
opportunity for me to thank
Je
Madame Amin
rappelle,
Bake for
Madame
her
Amin Baké
contribution.
au niveau de la
Madame
cellule
Amin
des spécialités
Bake
vétérinaires, qui est
is
précédemment appelée cellule
working
santé.
in
Et
the
comme elle dit,
primary
effectivement,
health
les
services
cases et les
cell
étoiles
in the ministry,
font partie
and
de la pyramide sanitaire. Ce que je voulais surtout préciser,
this
peut-être ce
is
qui est
part of
important,
the health service
c'est
pyramid.
qu'ils ne sont pas encore géolocalisés
They are not being geolocalized in the national
avec le DHS.
system of
On est
health
actuellement en train de
services. So presently we are working on
permettre à la fin de pouvoir apprécier
we are
la
working on implementing
communautaire dans
new information in order to be able to
santé au niveau national. Mais effectivement, CAS et
to
CIP
have an
font partie
overview
de
of
la
the
pyramide
national health
ici au niveau
system.
du Sénégal. Et dans les CAS même, nous retrouvons les acteurs
We are able to
qui
find
un peu le rôle de l'infirmier qui est au niveau du poste de santé à travers l'offre
The
de,
interpreter can't hear the floor.
à travers l'offre de soins au niveau communautaire. Donc, les soins de base.
At the community level, we have basic health services. Thank you, Madame Baquet, for this contribution.
Oui, merci, Monsieur Koulibaly. Donnez-nous une
Thank you,
minute.
Mr.
On va essayer
Kolibali. Please
on va
give
essayer
us
de répondre à la
a
deuxième
few
question et
minutes.
vous donnons la parole
We
dans
shall be
l'instant.
trying to provide
Donc,
an
la
answer
deuxième
to the
question
second
est
question.
adressée
So
au
the
Sénégal,
second question
Madagascar,
is
Sénégal, les deux.
addressed
Quel
to
est le dispositif
Senegal
posé
and
par le
Madagascar at the
ministère de la
same time.
Santé
What is
pour
the
les services en
facility
santé communautaire
implemented by the
après
health
l'obtention
services,
d'un
by the
diplôme?
Ministry of Health of your
Ces agents de
countries
santé communautaire ne sont pas suivis.
after
La
the
question est posée au Sénégal par
graduation
Alexis
of
Koulibaly.
these
Merci beaucoup,
community
Monsieur
health
Tian,
service providers?
de nous répondre
What
à cette question. À vous, Monsieur Tian.
does the
Ok,
Ministry of
merci,
Health do?
Monsieur Doudou. Donc, pour la question. Donc, dire
Thank
que
you for the
les
question.
spécialistes en santé communautaire qui sont formés à l'université à
We have specialists
sont
of
très bien intégrés
community health
dans la fonction
who
publique
are
sénégalaise.
being trained in the Bambi University in Senegal, and I am a product of that school.
Ressortissant de cette université.
And I am
Travaille au ministère
equally,
de la Santé où j'occupe vraiment des postes
that is equally my alma mater.
Vraiment,
So
sont vraiment
these
intégrés.
specialists and experts are
Voilà, ici au niveau du ministère de
being
la Santé.
recruited and implemented in the facility because today we are able to have them at the central and regional levels in health districts. They are major
Merci
actors
beaucoup,
in
merci
the health
beaucoup,
service.
Monsieur Birahim Cham. Donc,
Thank
Monsieur
you very
Koulibaly,
much,
est-ce que
Mr.
vous
Birahim
nous
Tian.
entendez
So,
maintenant?
Mr.
Est-ce que votre
Koulibaly, can you get
est
us
déjà,
now?
est-ce que ça marche?
Has
Ou un peu si vous nous entendez?
Is your connectivity stable now? Thank you. I
D'accord.
think
Merci
now
beaucoup. Et
everything is
vraiment,
stable.
chers participants,
Thank you
désolé
very
pour les
much,
inconvénients. C'est
dear
aussi
participants.
la question de la
We are
connexion
sorry
Internet que nous ne
for
maîtrisons pas toujours.
all
Comme
the
vous savez, dans nos
glitches.
pays, il y
You know,
a
in our
des endroits où on peut
countries,
avoir une meilleure
we
connexion,
have
d'autres pas du tout.
some zones
Donc,
with
Monsieur
better bandwidth
Koulibaly, voici la
and
première
others
question
with
qu'on
a
avait
very poor
préparée pour le
bandwidth.
Mali. Le
So
Mali fait
this is the
partie des
question we
rares
had for
pays
Mali.
à avoir
Mali
intégré
is
des
one of
agents
the
de
rare
santé
countries
communautaire dans leur
to
politique
having
nationale, et ce depuis
integrated
carrément
community
pratiquement
health
2018.
service providers in
Comment
their
cela a-t-il été
health
réalisé
system
et dans
since
quel délai le
2018.
Mali
How was
a-t-il
this
réalisé cette question? À
achieved,
vous,
and
Monsieur
how
Koulibaly.
was Mali
Vous avez la
able
parole. Merci.
to implement
Tout
this?
d'abord, nous nous excusons
Over
pour
to
cette
you.
interruption.
Thank you, and sorry
Et
again for
effectivement,
that
le
interruption.
Mali est dans le système de
Mali
santé communautaire il y a plusieurs années. Mais il est
is
important
in
également
the
que je puisse vous faire un
community
petit
service
rappel. Vous
providing
m'entendez?
sector for years now. Can
Nous
you
vous
get me?
entendons sain succinct. Vous pouvez y aller.
Bien, merci.
We can hear
Donc,
you
il est
loud and
important que
clear.
je puisse faire un petit rappel pour mieux
So it is
comprendre également le
important
système de santé
for
communautaire au
me
Mali.
to highlight some
Et
points
vous savez que
about
depuis après Alma-Ata,
this
le Mali
sector
a
in Mali.
évolué
You know,
vers la
after
création.
Amata,
Le système de
Mali
santé était
progressed
basé sur le système
into
administratif.
the
Et dès lors,
a system which
à
was
partir des
based
années 80, le
on
Mali a opté pour aller dans un secteur
administration,
beaucoup plus large
and
qu'on
since
appelle le secteur de
2015
santé de
we
base.
moved to a
Et ce
more
secteur de
global
santé de base, au départ,
system,
avait
which
permis
is called
déjà
the
la
base,
création
the
des
basic
dispensaires et des
health
maternités
system.
rurales. Et ces
It
dispensaires et
had
ces
to do
maternités
with the
rurales étaient dirigés par
establishment
certains
of
agents qu'on appelait
districts, health
les auxiliaires de
districts,
santé. Il s'agissait des matrones
which
et
was being
des aides-soignants
handled
dès le
by
départ au début des années 80. Et ces agents déjà faisaient
assistant
des
health
activités
service
communautaires.
providers.
Mais ils avaient une
They
formation de 6
handled
mois. Et pendant
community
ces
health
6 mois, ils
services
étaient
and
formés au
were
niveau du
trained for
district
6 months.
sanitaire et ils
And for
étaient
those
mis à la
6 months,
disposition de
they
la
were
communauté
working in the
pour mener
health
des activités de
districts,
santé communautaire à partir
providing
de
health
l'engagement des
services
populations qui
for
eux-mêmes
communities
s'organisaient pour leur construire les
from the
dispensaires et les
community
maternités rurales.
commitment
Donc après
in
cela et avec l'initiative de Bobako,
rural
et en
maternities. So
1990,
after this
le
stage,
Mali a mis en
in
place une politique qu'on
1990,
appelait la
Mali
déclaration
put in
d'objectifs sectoriels de
place
santé des populations avec l'appui des partenaires pour aboutir à la création des centres de santé communautaires. Et les centres de santé communautaires sont érigés
and
au
these
niveau
community
des
health
villages,
services
des aires de santé. Et
are,
chaque aire de
are put in
santé
place
a un centre de
in
santé
villages,
communautaire. Et cette aire de
and
santé
each
a
of
été
them
agréée
has
uniquement à travers le district
a
qui
health
est mis en
service
œuvre par
area
un agent, par
which is being distributed
le maître chef de
by
district
a
qui est
community
vraiment
health
l'agent
service
qui permet
provider
de faire cette répartition. Mais depuis lors, en 1990,
But
le
since
Mali a
then,
donné la responsabilité
in
aux
1990, Mali
communautés elles-mêmes
gave
de pouvoir construire
communities
leur
the
agence de santé
responsibility to
communautaire.
be able
Donc, les
to
communautés s'organisent
build
en
their
association et
community
mettre en
health
place,
agencies,
font la
and they
demande
were
de
able to put
construction de
in
centres de santé
place
communautaires. Et
an
c'est eux-mêmes qui prennent la gestion
agency
de ces centres
and
de santé
construct a
communautaires,
health
bien sûr
center.
avec l'appui
Today,
des
they are
autorités
able to
techniques
manage
et
those centers
administratives qui
with the
les
help of
accompagnent
the
sur le plan
of
logistique et autres
technical
aspects,
and
et même en termes de
administrative support
renforcement des personnels.
in terms of
Et l'objectif de
logistics
cette
and
mise en place de ces centres de santé communautaires était de pouvoir
expertise.
étendre la
The
couverture
objective was
géographique
to be
sanitaire
able to distribute
dans les zones les plus reculées. Vous
um,
savez que le Mali fait plus de 1,2 million km².
health
Donc,
services
il
all over
fallait
the
avoir
country.
un
You know
objectif
that
d'étendre la couverture
Mali's
afin que les
surface
populations puissent
area
avoir
is
accès à ces soins.
of
Mais
about
à partir de,
1
après 30 ans de mise
million
en œuvre,
meter square.
une analyse a été faite pour
And
constater
after
également
this
que jusqu'à
implementation,
présent, moins
we
de
were able to
50% de la
note
population
that
avait accès
less than 5% of
à
the
des structures de
population
santé
had
dans un rayon de
access
5
to
km. Et à l'issue de cela aussi,
health
et des
services in
réflexions
less
ont
than
apporté
5
à partir
kilometers.
de
And in
2015
this
pour
vein,
créer également la stratégie
there
des
was
soins
a
essentiels
think
dans la
tank in
communauté
order
que nous
to
avons appelé les
create
soins de santé
closer
communautaire.
health services,
Et cette
which we
stratégie
called
permettait à chacun
community health
de mettre
services.
en
And this
place
strategy was
dans un rayon
for
supérieur
us
ou
to be
plusieurs
able
kilomètres
to
d'un centre de santé,
implement
de mettre
or
en place un
establish a
site de
health
santé
service
communautaire. Et ces sites de santé communautaire devraient
from
avoir
a
une
less than
population entre 500
5 kilometer
et 1000 habitants
distance
en fonction des localités. Et
for
c'est cette stratégie
localities
qui a été mise en
inhabited
œuvre
by
à l'intérieur du gouvernement et qui a permis en
5,500
2011
or
d'étendre cela à
1,000
travers toutes les régions.
people.
Mais il a
And we
été
were able
noté
to
à partir
implement this
de 2017
countrywide
et à
in
l'issue de la rencontre de
2017.
Johannesburg,
At
de la
the
conférence
end
de
of
Johannesburg,
the
le Mali a
Johannesburg
organisé une
conference,
table ronde en
Mali
2021 pour
organized a
l'institutionnalisation du
roundtable
système de santé.
discussion for the
Et
institutionalization
actuellement,
of the
nous sommes
health
à l'élaboration de
system.
2 plans
And
stratégiques
presently, we are
pour faire
elaborating two
aboutir à ce
strategic
document.
plans,
Et également,
which
nous
are
avons pris
going
certains
to
textes qui vraiment
help
institutionnalisent
us achieve this
officiellement le tout.
objective.
Nous avons pris des
We
textes
have
pour
some
intégrer le
texts
système de santé,
for the
le système des agences de
integration
santé
of
communautaire à partir de 2022. Nous
community
avons
health service
élaboré un
providers
décret
from
qui fixe les conditions de
2022.
création et les
We
principes
enacted a
fondamentaux
decree
de fonctionnement
which
des centres de santé communautaire.
tables
Et à
on
l'intérieur de ce
the
décret, il y a
function of
deux
these
arrêtés
health
qui ont été
service,
pris
community
et
health
les
services.
arrêtés permettent de
Two
dire quelles sont les conditions de
paragraphs
création.
were
Donc,
taken
nous avons des textes
and
officiels
they
qui nous disent
discussed the
quand est-ce qu'il faut
modalities
créer des
of the
sites des agences de santé
operationalization of these
communautaires, quand
communities.
est-ce qu'il faut les
It
fermer et
discusses
quelles sont
the
les conditions de
sites, the
supervision et
establishments
comment
of
il
these
faudra-t-il
sites,
les
and
gérer.
when they are supposed
Donc,
to
nous
be
sommes partis
closed.
d'un
How
processus
are they
depuis 2000,
to be handled?
depuis les années
We
90
are part
jusqu'à
of
actuellement
this
en
system
2022
from
où vraiment nous avons
since
avoir tous
1990
les textes
till
nécessaires pour pouvoir gérer
2022,
un centre de santé
and we were
communautaire
able to
et
have
les
all of the
intégrer
texts
carrément dans le système de
necessary
santé
for the
habituel au Mali.
implementation of these
Voilà
systems
un peu quelques informations. Et nous
in
avons eu quelques
Mali.
résultats
So
dans le
these
système de
are some
santé communautaire au
insights.
Mali.
We have some
C'était ma
Les
results.
deuxième
données,
question. Merci beaucoup. C'était
voilà.
vraiment ma deuxième question.
Thank you.
Allez-y.
That
Merci,
was my
merci
second
beaucoup.
question, so you can proceed.
Allez-y. Je pense que nous avons fait un
Yes, you can go ahead.
c'est
I
un
think
processus long qui a
we
abouti à
have this
l'institutionnalisation du
is a
système de
very long
santé communautaire
procedure
depuis les années 80. Merci.
Merci beaucoup,
since
professeur Youssef
1990.
Koulibaly.
Thank
Cela veut
you
dire
very
que
much,
nous
Dr.
avons
Yusuf
un grand
Koulibaly.
temps que
As
le
you know, we
Mali
have
a commencé son
accumulated
processus.
30
Et
years
chaque jour, le Mali
since
essaie de
Mali
l'améliorer.
has been
Vous avez
working
fait une
in this
évaluation en
vein, and
2022.
it has been
Et en
going
ce moment, vous avez
progressively
refait
ameliorating itself.
des
And
décrets
presently,
officiels
you
qui
have put
permettent
in
vraiment
place
d'améliorer le
you
processus
have
qui a
put in
été
place official
engagé
decrees in
depuis
order to
bientôt
enhance
pratiquement 30
the
ans.
process
Je
that
pense
was
qu'on avait
launched
raison de
since
dire que le Mali est
30
l'un des rares
for
pays qui
30
a
years
d'abord fait
now.
ce processus,
And we think Mali is
puisqu'après,
one of
c'est
the rare
après la
countries to
conférence
kickstart this
internationale de
process.
Alma-Ata
And
qui a
from
permis
after the
qu'on donne la place,
Amarata
on reconnaisse vraiment la
conference,
place des agences de
this
santé
enable
communautaires
us to
dans,
acknowledge the role
qu'on
of
reconnaisse la place des
community
agents de
service
santé communautaires dans
providers
le système de santé.
in
Maintenant, je
the
voulais juste
health
vous
service.
demander
So,
rapidement, en 2 minutes, depuis que
so in 2 minutes,
cette politique des agents de santé
I would
communautaires
like
a
us to
été
recall
formalisée,
the role and
quels sont
the
les
poli
avantages
the policies analysis surrounding the advantages, the measurable advantages. What are the palpable results which we were able to take to notes
En termes
from
de
the beginning of
développement
this
interne,
initiative.
je pourrais dire, parce
As for the
qu'actuellement, le
concrete
système de
initiatives,
santé
what I can say
communautaire,
is that
nous avons
presently
les agents de santé
the
communautaires
community
qui
health
sont,
service
parce que le système de
is
santé
being
communautaire est partagé au Mali en deux.
put
Nous
in
avons les
place
agents de santé
by
communautaires, nous
is
avons le
being
département des
subdivided
agents
into
de
two.
santé
We
communautaire
have
dit de l'État
community health
communautaire.
service providers
Et
and
un des résultats
others.
palpables que nous avons,
And
c'est
one
que les
of
données
the
de
palpable
ces agents de
results
santé
that we
communautaires
have
sont
today is
inclus
that
dans
the
le système
data
de
collected by
santé
these
habituel, dans le
agents are
DHSH.
being
Pour nous,
included
c'est
in
un
the
indicateur
health
mesurable et
service.
qui permet de dire que
This
dans le système
enables
hospitalier au
us
Mali
to have
actuellement, nous
scalable
avons obtenu à ce que la
objectives
digitalisation de l'outil de collecte
and
des données a commencé par les
digitalization
outils des
of
agents de santé
data
communautaire.
collection
Tous les
tools
agents de santé
starts
communautaire au
with
Mali actuellement
these agents.
ont
All
des
these
outils de
agents
collecte de
presently
façon
have
digitalisée et qui sont
digital
interopérables immédiatement
data
avec les
collection
informations
tools
données par le
which
DHSH.
are
Donc, ces
being
données
provided and
alimentent
handed
le
to
système de
the
santé communautaire
administration.
habituellement. Et un autre aspect aussi est qu'avec les agents de
One other
santé communautaire,
aspect
vous
of
avez
these
vu que dans
agents
nos
is
présentations,
that
nous avons,
in our
chaque fois que nous avons des
presentation,
épidémies qui surviennent,
whenever
les
we
agents de
have
santé communautaire interviennent à un point important.
epidemics,
Et nous avons
these
mis en
agents
place des agents de
intervene at
santé
an important
communautaires
articulation.
sentinelles dans le
And
cadre de la
today
lutte contre la
we
COVID,
have
dans le cadre également
agents
de
working
l'épidémie de dengue qui est
in
passée
line
l'année
with the
passée. Nous avons
COVID-19
également mis en place des trucs.
since
Mais
last
quand vous
year.
vérifiez également,
And when you
les
look at
résultats nous montrent
what
que les
the
agents de santé
results,
communautaire font plus de 300 000 cas de prise en charge en matière de paludisme simple. Et ça constitue à peu près 15 à 20%
and they
du nombre
constitute
d'agents de santé
15 to
communautaire pris en charge
20% of the
de patients
number
pris en
of
charge dans le cadre du
agents
paludisme au Mali. Il en est de même pour les
in
prises en
Mali
charge par rapport aux insuffisances, aux infections respiratoires aiguës, où nous avons 13% des cas qui sont pris
working
en charge par
in the
les
respiratory
agents de santé
initiative.
communautaire. Et dans le cadre du suivi de la
In
malnutrition,
with
des
regards
données qui
to the
sont plus
follow-up
importantes, plus
in
d'une part
malnutrition,
des enfants suivis en matière de nutrition, dans le cas du dépistage de
children
la malnutrition, sont
survive
pris en charge par les
in
agents de santé
due
communautaire.
to
Donc, pour dire que les
malnutrition
agents de
are
santé
taken care
communautaire
of.
ont des données palpables
So
et visibles
the
dans le cadre de
community
l'échiquier,
health
en
workers
plus de
have
toute la documentation.
key
Actuellement, nous
information
avons au pays des
and
zones
they have
d'insécurité
key data in addition to
à cause
access
du
to
conflit. Et nous avons fait en
their
sorte que nous pouvons
ability to
prendre dans
access
ces localités des agents de santé
big
communautaire qui peuvent
zones.
intervenir dans le cadre de la vaccination,
They
qui
are able
interviennent
to
dans le cadre de
intervene
consultation prénatale et
when
même
it
des
comes
accouchements
to
en fonction des qualités.
enrolling
Donc,
or
parce
rolling
qu'il
out
y a aussi actuellement au Mali
vaccinations.
des agents de santé
So
communautaire
in
qui ont un
Mali,
niveau technique, ils sont qualifiés, mais à
these
cause des manques de travail,
people have
ils se sont mis comme
key
agents de santé
roles to
communautaire
play.
et nous
These are
parvenons
actually
dans les zones,
technicians, but
parce
due to the
qu'ils sont
lack of
natifs de
jobs,
la
rather,
localité,
they are
nous parvenons à les
forced to
utiliser pour mener
work
des
as
activités auxquelles les agents de
health
santé communautaire ne
personnel,
peuvent pas avoir accès.
and
Voilà un peu
they
quelques données
have
mesurables que nous
key
pouvons dire, en
information
plus de tous les
that
documents
some health
normatifs
personnel
que nous
cannot
avons
have
pu
help
mettre en
to.
place par
So,
rapport au
in
suivi des agents
summary,
de
this
santé
is what we're
communautaire.
able to
Merci.
put in place
Merci
in
beaucoup,
Mali.
Dr. Youssouf
Thank you very
Koulibaly.
much,
Merci vraiment
Dr.
pour
Yusuf Koulibaly. Thank you for that
le partage de cette impressionnante expérience du
impactful
Mali dans
experience you just shared about Mali
l'institutionnalisation des
as far
agents de
as the
santé communautaire
institutionalization
depuis
of
presque
community
3
health
décennies.
workers is
Et on vous
concerned.
remercie
And
beaucoup
we've
pour
learned
votre
that they
participation.
have been existing
Je
for
pense
over
que
3 decades.
il n'y a pas
I
de
think
questions.
in the
La
chat box, we do not have questions. We do not have
parce qu'on avait
any
déjà
questions
passé la
yet
session de
because
questions-réponses
we
juste
had
avant
discussed the
l'intervention
question
de
and
Monsieur
answer
Koulibaly,
session
Dr.
just
Youssouf Koulibaly.
before
J'aimerais
Dr.
vous
Yusuf
remercier
Koulibaly's
les différents panélistes,
presentation.
Monsieur
I would like to
Tiam,
thank the various
Dr.
panelists,
Ambiana Solo
Dr.
Henri de
Tiam,
Madagascar,
Dr. Henri
Dr.
from
Youssouf Koulibaly
Madagascar,
du
and
Mali,
Dr.
d'avoir pris le temps
Yusuf
de
from
préparer cette
um,
session, mais aussi de venir
Senegal.
présenter
Thank you
ici
very
et d'avoir
Mali,
aussi
rather.
préparé
Thank you
d'autres
very
points
much
avec
for
nous que mes
presenting.
collègues vont bien
And
partager
I
après
think
avec
that
les
our
participants
colleagues are
pour
going
trouver
to
vraiment un
share
document et
their
bien lire et voir
presentations with
comment
other
nos
colleagues
différentes
so that
expériences
they can read
enrichissent
further and see how
vraiment
they can
le rôle
enrich
central des agents de santé communautaire dans
themselves
notre
of the
stratégie
role
ici dans la région africaine.
of
Sur
community health
ce, je
workers
vais rendre la
in
parole à
the
Madame
African
Amarachi
region.
pour
That said, I'll give
faire
the
le
floor
mot de la
back
fin.
to Madame
Merci beaucoup,
Amarachi
Madame
for
Amarachi, et
the
merci et
next
bravo
phase.
encore
Thank
à
you very
vous.
much,
Merci.
Madame Amarachi, and
Thank you so
to you all.
Dr. Julian. You've done quite a good job with moderating this session. And thank you to our panelists who shared enriching experiences with us. Because of time, we'd just like to come to a close now. Colleagues, thank you so much for staying on the call with us. You have tried to sit with us and listen to these very enriching conversations. We would have taken a last Slido, but we are out of time. So just a few information before we close the session. We will be sharing with you a follow-up email, and in that email, we're going to have some of the conversations from the countries as PDFs for you so that you can actually go back and look at what the countries are doing and how they are doing it. And if some of these strategies can influence the way that you are doing things in your own country. Also, we have shared a survey in the chat. Kindly tell us what you think about the sessions so that it would help us to improve other sessions and other panel discussions. And in the spirit of building resilient communities, I would also like to thank our panel moderators, Elodie and Dr. Julian, for doing such a good job with moderating the conversation. And with that, I'd like to say good night. And thank you also to our interpreters for being on the call with us for this long. And thank you to our IT team for being on the call with us too. Thank you, colleague. We bid you a good night, a good afternoon. And we hope to see you in the next session on evidence-based RCCE strategies. This will be on the 7th of August. And we will be sending you invitations. Do well to register and mark your calendars. Have a good night, a good afternoon, everybody.
Bonne soirée.
Bonne soirée, au revoir.
Merci beaucoup. Au revoir, Deborah.
Merci beaucoup.
Au revoir. Au
Au
revoir.
revoir.
Au revoir et bonne soirée.
Merci.
Au revoir.
Au revoir.